It's nice to be back in Amsterdam for this meeting and to really get together and talk about how's it going around elimination. As Jordan and Margaret said, to really get into the how-to, that we can share best practices and our experiences to learn from each other. And I'm going to be finishing up on that note as I talk about this global movement. So I sort of spent the summer after moving on from being division director of a division of viral hepatitis for 13 years, really sort of immersed myself in looking at disease eradication and elimination as a public health endeavor. And when you seize on disease elimination and eradication goals for particular reasons and after certain criteria are met. And what you're really talking about are different stages of disease control, with eradication being the most successful, if you will, where the organism's completely eliminated, no reason to continue prevention measures. Smallpox is really almost the sole example in that regard. Then you have elimination, classically meaning no cases in a particular region, but preventive interventions continue to be necessary. In actual fact, many elimination goals are proportional decreases or numerical decreases in the number of cases to reach numerical targets. And then in 1997, the WHO introduced the concept of eliminating diseases to eliminate a public health threat, which, and the definition of that can vary based on an assessment of health system capability, epidemiologic circumstances, et cetera. And so that's been used, and that, as you'll see in a moment, has been applied, in our case, to viral hepatitis. Now, the overarching reason that, from a public health perspective, that you get and set goals for elimination and eradication is health equity. You're really trying to assure that everybody can benefit from a particular highly effective intervention to prevent transmission and disease. The goals are to achieve that time-limited goal to reach that target for disease elimination. But the secondary goal, which I think is also important, is to leave behind a stronger health system. So you're not trying to develop a silo program that just disappears after you reach your target, but has had some long-lasting benefits. And I think you'll see examples of that as you look at the presentations today and tomorrow. From a programmatic level, the value of elimination is that those time-limited targets really drive prioritization of what you're doing. It creates a sense of urgency to get the mission done. It sets goals for accountability so you can track progress and identify areas for improvement. And really, that elimination concept really attracts stakeholders, and there's multiple examples of that. Now, the attention to viral hepatitis that led to elimination began some time ago by, as a case in point, multiple resolutions from the World Health Assembly pointing out the rising mortality associated with viral hepatitis and the lack of prevention interventions being applied. And this only gathered more momentum with the licensure of highly effective therapies for hepatitis C. The United Nations joined in by adding to the Sustainable Development Goals a mission to combat hepatitis, the first time that was mentioned in that, at that level. So that was sort of put the wheels in motion of developing the elimination goals, as one of those resolutions was directing. And so, as a result, the WHO passed, put forward a set of recommendations that was endorsed through a resolution of the World Health Assembly, that there would be goals for elimination of hepatitis B and hepatitis C as public health threats by 2030, 65% reduction in mortality, 90% reduction in incidence, and in that process you could avert over 7 million deaths. So that sort of sets out what's your health impact. Now you can go in this direction and set goals for elimination because Hep B virus and Hep C virus infections meet certain criteria. Number one, this is a major public health problem. I didn't go in great detail here because I think many people in the room know this, but we have almost about 1.3 million deaths from hepatitis B and hepatitis C. Secondly, it's biologically feasible to consider elimination Humans are required for replication. There's no intermediate host. There's no replication in the environment. You have technical feasibility because you have highly effective interventions. You have a very good hepatitis B vaccine, interventions that interrupt bloodborne exposures, testing and treatment that can have an impact on transmission and obviously on interrupting progression to life-threatening end-stage liver disease and liver cancer. And then you've had global endorsement by highly authoritative bodies who provide opinions on elimination goals. And that has set in motion. We now have regional plans in almost every region of WHO now, bringing together a comprehensive public health approach for elimination. So that's a very positive part of the movement. You have global awareness campaigns from the World Hepatitis Alliance that's seeking to raise awareness around the concept of elimination. So that's another sort of positive step coming from the setting elimination goals. And then from those different interventions, the WHO has set implementation targets for the different interventions for vaccination, interrupting bloodborne transmission, and diagnosis and treatment. So you have, again, those numerical targets are important. The other thing I like to really emphasize is that even though the goals are new and the plans are relatively new, the progress toward elimination really began some time ago. And when you read up on elimination, it's quite okay for elimination, the progress toward elimination to begin before a formal structure is developed. And that's really true for blood bank screening, where you've had tremendous improvements in blood bank screening for hepatitis B and hepatitis C, large reductions in transmission to where it's virtually eliminated when all the testing is put in place. What remains to be done in some countries is that not all of that testing is being done, so there's a continued need for quality improvement, sustaining what's already been put in place, but that's a major advance. Secondly, large reductions in bloodborne transmission in healthcare settings, where you've had an 88% decrease in the proportion of injections administered with non-sterile equipment, 91% reduction in Hep B transmission, 83% reduction in HCV transmission. So that's a big win. That's the most, blood banking, poor infection control, leading cause of HCV transmission, as you, I'm sure, are aware. So this is a major improvement, yet we still have 5% of all injections globally are administered with unsafe equipment. That proportion is higher in certain areas. So it's still a need for improvement, but let's recognize the great accomplishment to date. Oh, shoot, let's see here. Well, how do I go back? Let's see here. The other improvement has been the improvement in infant immunization with a 3-dose series of hepatitis B vaccine, in part because of the Global Alliance for Vaccine and Immunization, or Gavi, support for Hep B vaccination, and the development of combination vaccines. So you're up to about 84% of infants now globally receive an infant hepatitis B vaccine, and you've prevented something like 15 to 20 million infections because of that. The goal for WHO is to improve that coverage to 90%. And if you can improve it from 84 to 90%, you will prevent an additional 4 million chronic hepatitis B infections between now and 2030. So a good job, but more needs to be done there. The other big need for a vaccine is implementation of the birth dose reliably. As your infant immunization decreases horizontal transmission, an increase in proportion of chronic infections that are attributed to transmission at birth. So birth dose delivery and in a timely fashion is increasingly important. And we know certain strategies increase coverage both in facilities and for home births, and maybe we'll be hearing a little bit about that. Scaling up to 80% from that 43%, we can prevent almost 19 million infections between now and 2030. So that's a tremendous payoff. And so that's why this is really a high priority. The good news is that Gavi has developed an investment case which prioritizes the value of Gavi supporting the purchase and administration of the birth dose in Gavi-eligible countries. And they're going to be voting on that in June of 2019, and that will be an additional wind in our sails, so to speak, of eliminating this mode of transmission. Some countries have really come together, most notably in the Western Pacific region, of setting very ambitious control targets for hepatitis B based on full delivery of infant immunization and the birth dose. And many of the key essential components for elimination programs are really represented by them coming together: numerical targets, political support, evaluation data to track progress, and then continuous quality improvement. And that's what you really need for successful elimination programs. The remaining challenges, which I would think Margaret will be touching on, is key challenge for hepatitis C is the high risk of transmission among people who inject drugs and the poor prevention infrastructure to interrupt that transmission for those populations. In almost all countries, except the country that we're in, and in other countries like Australia, where you have a high number of syringe and needle exchanges for every injection drug user per year to reach that over 200 threshold that WHO considers to be a good marker of prevention. The other big challenge is that most people still do not know their status, are not in care and not getting treatment for hepatitis B, and not getting treatment and cure for hepatitis C. And this is a global problem in almost every country, and many of the elimination programs now are really focused at looking at that. And we have some notable examples of when you put the program together with some highly effective interventions that cascade and linkage to testing, care, and treatment greatly improves. Georgia, which is represented here, Tingez and Valerie have been colleagues over the years as they've started up this program and really made a remarkable, put together a remarkable program that has treated over a third now of people with hepatitis C in the country using key tools that are listed there: national planning, again, strategic data, various efforts of health system strengthening, as you'll be hearing about in a moment. Also, other notable examples, which also are represented in the room today, are the group from Iceland that's published at least 2 papers on this, showing how they've really been targeting people who inject drugs in that community, but bringing together multiple stakeholders, coalescing around a national plan that puts together a multidisciplinary public health approach there. Egypt has had a goal for elimination for quite some time. They put together a very effective treatment network. But in February of this year, President al-Sisi really upped the prioritization by calling for the elimination to be accelerated to 2020 rather than 2026. And then testing a campaign to test everyone between the ages of 19 and 59. We'll be hearing more about this, I'm sure, but the data I had available for this slide suggests that at least 8 million people have been tested since that time. So it really shows you need technical proficiency, but that political commitment cannot be understated. When you really get the key leaders, such as the president, behind you, it really, really helps. There are other examples who aren't represented here. The Cherokee Nation of eastern Oklahoma is an example of a program in the United States, which they have put together tools. Most notably, in my opinion, mid-level providers, pharmacists, provide at least a third of the treatments in the Cherokee Nation rather than requiring specialists to provide that care. There are other programs that are just beginning. This is from Dr. Pouvaron, who was unable to come today, but they have just recently completed a serologic survey to identify the populations at highest risk for hepatitis C in one particular province in Thailand, targeting testing based on that data, getting affordable medications and treatments, medicines and diagnostics in place, and then using that local provincial program to scale up to a broader group. And that's what I really think is what microelimination projects, as they're called in hepatitis C, should be. They are really field studies that can be put in place in different settings, provincial level, in a health system, in a correction system for a particular population, such as people with HIV, and benefit that population. But they really should be put in place with that whole concept of we're going to learn from these programs and scale it up to a broader community or the whole country, and really get that health equity in your mind as the ultimate goal, that everybody should be benefiting from this program. And then, as part of our movement, we have 34 countries represented in the room today. And all of you have something to share that we can learn from. And as Jordan said, that's the whole idea here, is to really work together, as a community. And that's something that I've moved over to the Task Force for Global Health, and to really, after 2 years of really working with them to come on board and help us with our elimination efforts, they have a lot of experience in building these communities of practice around disease elimination targets. They work in that way for their neglected tropical disease elimination activities, eliminating trachoma, which is a leading cause of blindness. There are other examples for other disease elimination programs: polio, malaria, TB, HIV. And they really work by, and the reason why I think they're important for viral hepatitis is that we're trying to prevent transmission and disease, so that requires multiple interventions. We have limited resources, so collaboration is one way of being more efficient and effective. Many elimination programs are new and just getting started, so they can learn from those who are ahead of them. The key information is fragmented. It's published and presented in multiple places. How do we get that together? Where is there an opportunity for some expert technical assistance that may not be able to be provided by WHO alone or CDC alone? And how can we work together to identify key operational research priorities because they're being recognized all over the world? So we've come up with a basic program. We want to get the key policy developers involved, like WHO, key civil society representation, like World Hepatitis Alliance, people supporting elimination. That can be pharmaceutical companies. It can be NGOs, et cetera. Get them involved so that the program at the task force knows what's going on around the world and is contacting the implementation partners to get them involved in this network to become this community of practice. So, and then we're building an expert database that's been vetted for quality, and then having information tools come from that that's readily understandable and usable at the local level. And for them to be useful at the local level really requires your feedback, so that the program knows what's the most helpful to you. And then we'll have a public face so that the work that's being done around the world is readily available. We thought about the concept of an interactive map where you could click on a country and then see what's going on at a national, subnational, microelimination level, and have points of contact to promote that information sharing. So we have that development underway. I met with some participants of this conference earlier this morning who were nice enough to come early and talk a little bit about this program. I would love to talk to anyone who would like to learn more about this and how this program might help them. But in summary, we have a rare opportunity in public health, which is to participate in an effort to eliminate disease and have the consequences of that being major improvements in health. I believe we've already had substantial progress toward elimination that I've outlined through vaccination and interrupting bloodborne transmission. We have model programs, which I gave you just a very small sketch of, but we'll be hearing more about today and tomorrow. We provide examples of best practice. Then I think going forward, meetings like this, I hope the program, that I'm developing at the task force can improve our collaboration and information sharing efforts so that we can be as effective as possible for the programs already underway, and then help other countries get off the sideline and into the business of hepatitis B and hepatitis C elimination. So thank you very much.